I am a professor in internal medicine and health management and policy. I work in the area of ethics and health policy. I chose to do healthcare research, and in particular health policy research that has to do with ethics issues, values issues, justice issues, based on curiosity. I like answering questions. I've always been somewhat a curious person. I hate boredom, so I'm never bored in this field of healthcare research, health policy research, and just an abiding passion for issues of justice and ethics. So that's why that mix. My research really is about, how do we share fairly? So healthcare uses pooled resources, whether it's private insurance or public insurance or a national health system like they have in other countries. It doesn't matter. You have pooled resources to meet individual needs. And so the research I do that asks patients and the public, as well as others, how can we share fairly? What should we cover with health insurance when you can't have it all? What should we not cover? What should people pay for themselves if they want it? Those are questions I think that will continue to need answering. Choosing altogether is a simulation exercise, sometimes called a serious game. I designed Choosing Altogether, otherwise known as CHAT, many years ago with a colleague who works at the NIH, Marion Danis, in order to get public input on how to allocate limited resources in healthcare. One of the things we found is that after going through the CHAT exercise, they're more likely to agree that we have to watch what we spend, that we can't have everything because of the fact that resources are limited. They also will make choices that tend to be different from the kinds of health insurance that we have on the private marketplace. So for instance, pretty much by historical accident, dental care has never been covered by health insurance. But people recognize very well the importance of teeth and mouths for their health. And it's always one of the top chosen categories of coverage when they're using limited resources to design a health insurance plan, say. And we've also learned that people, when they deliberate together about the use of pooled resources, that they can do so in a way that uses good reasons and that they can live with. If you can live with the result, then you thought it was good enough, fair enough, to make that kind of policy decision that way. How do we decide when a patient doesn't get something they want in healthcare because of cost, because somebody else has a more just claim to those limited resources? That is a very tricky problem, and especially not limited to doctors, but especially for doctors, when our professional role is to be a patient advocate. That's a big problem. I know I'm biased, but I think it's a big problem, and I think it'll continue to be one. I became a member of IHPI basically as soon as I could. To me, it was obvious that this sort of multidisciplinary group of people studying health policy, coming together in one place, being able to exchange ideas, it was just obvious to me that it would help my work. I was approached about joining a group that will be evaluating the Michigan Medicaid expansion, known as Healthy Michigan. And I never would have had that opportunity without IHPI. I've seen it change even over the 20-odd years I've been in practice, from an emphasis on history and physical to technology. And an emphasis not just by doctors, but patients too. If you don't do a test, then somehow you haven't evaluated a patient. Maybe an increased emphasis on primary care, as we're seeing in health policy now, both with the Affordable Care Act and also with things like the Michigan Medicaid expansion, which emphasizes primary care. I certainly think that IHPI will and can improve health and health care in the state of Michigan and beyond.